Type 2 diabetes management. Remember, all patients with type 1 diabetes should be seen an endocrinologist, as that's not something generally managed in family practice. Checking a hemoglobin A1C at least every 3 to 6 months is important. If they're not at goal, which ideally is less than 7%, then you need to make sure that you're having them follow up with you more often and that they're getting their blood work done every 3 months. Of course, any hemoglobin A1C of 6.5% or greater is considered diagnostic for type 2 diabetes. Normal adult is less than 5.6%. Increased risk or pre-diabetes is between 5.7 and 6.4%. I typically use a pre-diabetic dot phrase that I've created to put that they're at increased risk of diabetes or pre-diabetes, and recommending that they work on reducing carbs and sugars and fats in the diet, getting exercise, and losing weight in order to prevent or decrease the risk of developing diabetes. The treatment for diabetes is quite diverse. There's a lot of choices to pick from. Generally speaking, if there's a patient who's newly diagnosed with type 2 diabetes, typically I prescribe something called metformin. Metformin is extremely cost effective. Most insurances cover it, and it's just a good first choice for patients. However, there are some patients who just do not tolerate metformin. Typical side effects, of course, can include abdominal upset, diarrhea. Sometimes giving the extended release tablets prevent that or help to correct that. So normally I prescribe only the extended release tablets, whether it's 500 to 1,000 milligrams once daily as a dose. You can drop someone's hemoglobin A1C by 1 to 2% with metformin alone typically. And then if you think about it, if they're newly diagnosed, hopefully they're working on some dietary things as well to reduce down their numbers so that not only does the medication help, but their diet changes help as well. Byetta is considered a GLP-1. It kind of works with your pancreas in order to help it spit out more insulin to cover, your meals and stuff. It's not something that we use very often, or at least I don't really use it very often in practice. I more commonly use Trulicity and Ozempic. Just because they're covered better by the insurance. Now, Victoza is always an option as well. Again, I don't find it covered as well by insurance. They relabeled it to call it Saxenda. It's a medication used for weight loss. Again, insurance kind of dictates whether or not patients can use Saxenda for weight loss. Sometimes we prescribe it, Victoza, for type 2 diabetes patients so that it can encourage weight loss. Of course, with any GLP-1 medication, it can cause nausea, GI side effects. Some people have vomiting and that sort of thing. So just make sure that you educate your patients on any of that. The thing with any of the GLP-1s, for the most part, is that you have to inject it. And so Victoza is once daily. Trulicity is once weekly, and Ozempic is once weekly. The only one that comes in an all-inclusive pen is Trulicity, where it actually has the needle. Otherwise, Victoza and Ozempic, you have to also prescribe the, the needles that kind of get screwed onto the pens themselves. Ribellus is the pill form of Ozempic, which is interesting. They came out with that. I don't find that it's covered very well by insurance since it is such a new medication, but it's supposedly helps with them losing weight, and it works similarly to the injectables. That would be 3 milligrams once daily for 30 days, and then you can kind of increase it if you need to, depending on their glycemic goals. And that kind of works for, of course, all the diabetes medicine, is that you want to make sure that you get it to a therapeutic goal. Any of the GLP-1s, you typically start it at a lower dosage because it's more generally well tolerated. If you start it at higher dosages, the body sometimes can have more side effects like nausea and GI upset, and patients are more reluctant to continue the medication when those things do occur. With any of the GLP-1s, it can take sometimes up to 4 weeks for it to become therapeutic in your system. And so it's a while for their blood sugars to kind of go down over time. So educating patients that it's not an immediate solution to getting your numbers down, so that they have to be patient with it as well, is important. And certainly they can be on metformin and a GLP-1 at the same time if necessary based on their blood sugars and their hemoglobin A1C. Other medication choices are SGLT2 medications. That includes Invokana, Jardiance, and Farxiga. Those medications, essentially you're urinating your sugars or peeing out your sugars. Sometimes the side effects for these medicines, since you're peeing your sugars, includes yeast infections. I've seen this frequently in men and women where they can get recurrent yeast infections from this medication. And so if they are getting recurrent infections, simply just discontinue it and try out different medications that are in a different class. It's just not a reasonable thing to continue them on that medicine if they're having recurrent yeast problems. So sometimes some of these classes aren't always covered again well under insurance. I prefer Jardiance out of this class because it reduces the risk of heart disease. However, sometimes Jardiance isn't a choice. Insurance dictates we prescribe Farxiga and Invokana instead. It's just, again, see kind of what happens in your terms of your choices with insurance. And you also need to keep in mind the patient's kidney function as well. You definitely don't want to cause any sort of kidney issues by prescribing medications that could potentially hurt them. So if they are seeing nephrology or if they have a GFR that is below 60, you kind of want to be more aware of what's going on to make sure that you don't cause any problems. In terms of DPP-4 inhibitors, Onglyza and Januvia, I really don't use them very often. I don't feel that they work very well in bringing down blood sugars. It's typically one of those last resort kind of things when a patient, is coming in and saying, hey, I drive a truck for my DOT, I can't be on any, insulin, and, what can I be on? And they're already on some of the other classes of medication, and this would be a choice that you could pick from if necessary. I use it as, again, like more of a last resort. Tradjenta also is a DPP-4. Again, I typically don't prescribe it that frequently. Certainly you can use it in renal or hepatic impairment patients, which is kind of nice, but again, it doesn't reduce down their hemoglobin A1C as much as some other choices that you have to pick from. And glucotrol or glipizide is something that most insurances cover. It's super cheap medication like metformin is. The only thing is it can cause weight gain, which is not ideal when you already have a diabetic patient, and it can also cause hypoglycemia. The good news is, though, you can use it in any patients who have kidney issues, so it is used quite frequently. They make an extended release of this, which is nice. So they only need to take it like once a day, so that's really, really convenient. Actos is another medicine that you can prescribe as well. Again, I don't use this very frequently, but if you do have a patient with kidney or liver issues, it's another alternative choice to use. Just be careful with your patients who have heart failure or who have edema issues, as it can worsen heart failure and cause edema. Just something to think about in terms of side effects of Actos. Then you have your insulin, your long-acting Detamir, which is also known as Glargine. It's something you can prescribe if you need to, based upon what other medications the patient is on for type 2 diabetes. Typically, initial dose is 10 units, at bedtime. However, you can also base it off of the patient's weight. That would be like 0.1 to 0.2 units per kilogram once daily. And you could even do it in divided doses, like in the morning or in the, before bedtime if you need to. So it really does depend, again, upon your patient's needs. A lot of times, if that's not covered, Basaglar is typically covered. Basaglar, also known as Lantus, also known as Toujeo, is one of the three, typically is covered under your patient's insurance. Again, that's just 10 units once daily, or again, you can weight base that if you need to, based on what their fasting blood sugars are and what their hemoglobin A1C is. Also, if you do trust your patient to be able to correct their fasting blood sugars in the morning time and manage their medications on their own, you could give them this information that every 3 days they could increase by 2 units until their fasting levels are between 70 and 130. However, if their blood sugars are not, they can increase by 4 units if their blood sugars are greater than 180. And they would do that every 3 days on their own. They could manage and kind of increase their long-acting insulin if necessary. Of course, if you end up where they're having hypoglycemia issues in the morning time, you definitely want to tell them that they should reduce their dosage at least by 4 units or more, just dependent upon how low their blood sugars are getting. So just some information and education to provide to patients if you're comfortable with them kind of managing their long-acting insulin at home. If you're not, then close follow-up, of course, is extremely important in these cases, as you want to make sure that their diabetes is managed and doesn't get out of control. In terms of short-acting insulin, there's some choices with Humalog or Novolog. We base it off of a sliding scale. Not everybody needs to be on short-acting or even long-acting insulin. Again, there's a lot of other choices to pick from. Not a lot of patients are going to want to give themselves a bunch of shots for their management of their diabetes. They definitely prefer taking pills. They definitely don't want to have to check their blood sugars constantly, like 4 or more times a day. Especially with your non-compliant diabetics, if you could help it, trying to give them pills over insulin, is easier, or even giving them the once a week injectable like Trulicity or Ozempic, where they can just manage that shot once a week is more important, again, to try to manage their diabetes. However, if you do need to use a sliding scale, this is kind of a starting point that you can work from. Now, every sliding scale you can change for your patient if necessary. This is just kind of a basic sliding scale. There are, of course, sliding scales that start at, 4 units or even 10 units. So it really depends on your patient's needs, for getting their fasting blood sugars to be goal, which again, goal would be less than 130 ideally. A lot of endocrinologists prefer it to be even closer to 100. So really, you want to work closely with patients to make sure that they're meeting their goals. As we spoke, goal fasting blood sugar should be less than 130, and the goal would be to have a hemoglobin A1C of less than 7%. I educate all my patients that in order to prevent other comorbidities associated with diabetes like cardiovascular disease, heart attack, stroke, congestive heart failure, chronic kidney disease requiring dialysis, peripheral neuropathy, and peripheral vascular disease that could lead to loss of limb and loss of vision, that they really need to work hard on getting their diabetes under control and managed. If they do not, these are the things that could happen to them. Certainly they need to make sure they're watching their diet, trying to get some exercise, trying to work on weight loss. A lot of the medications for diabetes do encourage weight loss, like metformin, and any of the GLP-1s, even the SGLT2s like Invokana, Farxiga, and Jardiance can encourage weight loss. So ideally, those are the choices that you want to pick if you can, and try to avoid like any of the glucotrol or glipizide, as it can cause weight gain. The goal again is to try to get their diabetes managed, help them encourage weight loss, help them make sure that they want to take their medications and they're not having major side effects with their medications. That's the ideal. And then if you need to lean on any of your referrals, whether it's diabetes education for newly diagnosed type 2 diabetes patients, or someone who's, has non-compliance, or they're having some confusion about what their diet should consist of, sending them off to diabetes education may be helpful. Sometimes they, of course, don't keep their appointments because they don't want to go because they're non-compliant. So sometimes providing information while they're at the clinic, while they're with you, in regards to how to manage their diet is important, because that might be the only time that you get to see them before they go off and everything. Otherwise, you can certainly send the patients to endocrinology if you need to, for patients who are requiring massive amounts of insulin or just are extremely non-compliant. Endocrinology may be able to assist those patients and get them on a better track with everything. And lastly, your choice is a nutritionist if you need to, as they can help, again, with some of the dietary components for this. There's a lot of different meters that patients can have. There's a lot of talk about the Libre meter as well as the Dexcom meter. Unfortunately, they are not covered under insurance unless your patient is on insulin. There is no point in ordering any of those, the Libre or the Dexcom, if they are not on insulin. They're covered, of course, for all patients who have type 1 diabetes, as they're insulin dependent patients. Otherwise, endocrinology may be able to assist getting that patient a Libre or a Dexcom based on their really poor control of their diabetes. But generally speaking, it's not covered. So they're really going to have to be working on checking their blood sugars at least once a day, keeping a good logbook of their blood sugars, bringing that logbook or their meter or both to their office visit so that you can follow up with them and review their numbers and make sure that they're at goal. Again, goal would be less than 130. So if they're not at goal, you want to adjust their medications accordingly. So you can maximize them out on the medications that they have on hand. So that would be, maximizing them on metformin, maximizing them on Jardiance, for example, adding glucotrol if you have to. You just need to pick from each class of medication that's necessary to get their numbers down where they need to be, based again upon insurance coverage as well, because you'll find a lot of times some of these things are not covered. If they're not covered, you can certainly, try to give them coupon cards to see what they can do. There's some helplines and things online that they could get insulin through at more of a cost-effective price. They can try to use the GoodRx app, although that usually doesn't work as well for the diabetes medications, as they're quite costly and expensive. And so close follow-up with those patients is important to make sure that A, they are able to get their medication, and B, that their diabetes is getting managed and under control. So whether or not you need to meet with them, in 2 weeks or 4 weeks to see where their numbers are, or even, rechecking again their hemoglobin A1C in 3 months to see where those numbers are lying. That's extremely important in cases like this. And then relying on, endocrinology if you have to kind of guide you further if you have a really difficult to manage diabetes patient. And I'm always really honest with my diabetes patients, explaining to them that they're on the maximum dosage of the medications that they're on. And so at that point, they're kind of backing me into a corner, so to speak, in terms of what my options are for additional medication. And that typically lies into this, saying, hey, you're going to most likely have to be on insulin unless you correct, some of this diet stuff, unless you work on this and that. So, I think it's extremely important to be honest with your patients so that they know, sometimes you do run out of oral medications like pills that you can take, and that's going to require injecting something, whether it's a GLP-1 or insulin, to get these blood sugar numbers down, because you can't let them run around with a hemoglobin A1C of 9 when they're already on 4 oral medications. It's just not ideal. And so having these frank conversations with them kind of lets them know that you're trying to work with them, but at the same time, their options are getting far and few between. Things also become more challenging as well when they have allergies, or side effects to, like metformin, for example, when it causes them, GI issues. And even the extended release does that too. And then you're really limited on some of the choices if their diabetes is uncontrolled. So again, just having these open dialogues with your patients helps to kind of narrate where things are headed if they don't get things under control, relatively soon. All right, thanks.